Hello and welcome to the 2024 American Psychiatric Association annual meeting, Psychiatric News Highlights video series. I'm Dr. Adrian Preda, the editor-in-chief of Psychiatric News. My guest today is Dr. Michael First, who just delivered the presidential lecture on psychiatric diagnosis at the Crossroads. Where do we go from here? Michael, you are the editor of DSM-IV, Text Revision, the editor of Text and Criteria for DSM-IV, and the APA Handbook on Psychiatric Measures. You have co-authored and co-edited a number of books, including a research agenda for DSM-V, the DSM-IV Text Revision Guidebook, the DSM-V Handbook for Differential Diagnosis, and the Structured Clinical Interview for DSM-V. And this is just a little selection from the many things that you have done, books and so many peer-reviewed publications that we don't even have the time to start with. You're a professor of clinical psychiatry at Columbia. You had a fascinating lecture today. But before we get into that topic, I'm actually curious how you got interested in the whole issue of psychiatric nosology, classifications, and diagnosis.
It's easy and complicated in the sense that when I was in medical school, I was involved in a project of doing a diagnostic expert system at the University of Pittsburgh. There was a very famous computer science person who wanted to do computer-assisted diagnosis. So I worked in that project, so I became very interested in that topic. And then when it turned out that I was going to end up going into psychiatry, I got interested in that direction. So when it was time to interview for residency, when I got to Columbia, Robert Spitzer, earlier in his career, was interested in using computers for doing psychiatric diagnosis. So I thought that would be a great place to go. And so I went to Columbia for residency, and I never left.
So you started working with Robert Spitzer, was by then the DSM-II.
No.
He worked on DSM-II before. He had some experience, but then
right.
He took over the DSM-III.
Right. When I came there, it was the last year of 3R.
Okay.
So I was able, because of that, I was able to actually contribute to the 3R for the last year. And then he was a fabulous mentor. I mean, really, really amazing knowing him.
So we had DSM-1, 2, 3, 4, 5, text revision, right? And other text revisions for 3 and 4.
Right.
Many different editions. You've been part of the DSM life cycle for a long time. Could you just summarize kind of what were the DSM milestones through all the different, the many editions? What were really the major changes to the DSM editions?
Well, the version that put the DSM on the map was DSM-3. DSM-1 and 2, most psychiatrists didn't even have it. They had no interest in it. That was at the time that psychodynamic, psychotherapy, psychoanalysis was big, and they didn't care about symptoms. I mean, the symptoms were, there was, a epiphenomenon of the conflict, so nobody cared about that. So, DSM-1 and 2 were really very little interest. They're used in mental hospitals to help classify patients. DSM-3 was the first one that really made a difference. And the thing about DSM-3 that made it really useful is they developed diagnostic criteria for every single disorder in the DSM. So they had a lot of positive effects. One was psychiatry was really in a bit of a crisis at that point as a specialty. People felt it was unscientific. It's very low esteem to psychiatry. And the DSM, when it came out, made it look much more scientific and robust than, so people got newfound respect. So people just flocked to it and really started using it, and it really helped them make more reliable diagnoses. So that was the point where it really took off.
So that was DSM-3, almost like a qualitative change from DSM-1 and 2.
Yes.
And then we had the DSM-3 text revision, and then
that was actually DSM-3R.
DSM-3R,
because that's a full revision. So the reason it's not called DSM-IV, people always wonder that.
That's the question.
The DSMs are connected to the International Classification of Disease because the codes in the DSM are from them. So they need to be coordinated at some level. And in fact, DSM-II was the first one that they actually worked with WHO to coordinate it. So each time there's a ICD revision, that is an opportunity to do a DSM revision. So DSM-II is connected to ICD-8. DSM-3 was connected to ICD-9. And they knew when DSM-3 came out that when DSM-4 would come out when ICD-10 did. So that was already set. The problem was is that after DSM-3 came out, it was popular, but they also found mistakes in it. They wanted to put a version out before DSM-4. So that's why they came up with the name of DSM-3-R as a revision of DSM-3. But it's really it's pretty major changes in DSM-3-R.
What about DSM-4?
So DSM-4, there was a change in the DSM-4. I mean, DSM-4, the big news for DSM-4 is that they took the idea of empirical footing for diagnosis very seriously. Mm-hmm. So there's a couple of things going on. Number one, if you put too many changes in DSM-4, there may have been a rebellion among psychiatrists. They just bought DSM-3. 7 years later, you got DSM-3, or 7 years later is DSM-4. Mm-hmm. So people would say, what's going on? That's just too much. So Alan Francis, who was the chair of the DSM-IV, very smartly said, we have to focus on another reason for doing the DSM-IV, partly because people were getting very suspicious that it was being motivated by financial concerns. Mm-hmm. So his reason, which was brilliant, was the whole process of DSM-IV was making the whole thing much more empirically based. It was a big endeavor where people were doing literature reviews and field trials. The literature reviews were informal for DSM-3. They actually had a whole process. People were experts in doing literature reviews. So that was the focus of the DSM-IV revision process. There were lots of changes in DSM-IV, but the reason to do DSM-IV, besides the fact they needed to do it for ICD-10, was, and that's how the emphasis on DSM-IV was the process of how it. So the DSM-IV has source books, just to document. It's a very, very serious process. And I think that was the big thing about DSM-IV.
And then the revision of DSM-IV.
There was a text revision. So what happened there was, after DSM-IV came out, the APA wanted to we can't be doing DSMs every 7 years. We want to wait. And they slowed down the whole process. Mm-hmm. But the problem with that is the text in the DSM is something that people use as a textbook, medical students, residents. So the longer they put off DSM-5, the more stale the text in the DSM-IV would be. So they had the idea of, let's just do a revision of DSM-IV that focused on the text itself. And did all, so basically the text was rewritten to reflect the most recent data. You can imagine prevalence data gets very out of date very quickly. So things changed through the entire TR.
So would it be fair to say in the text revision for DSM-IV there were maybe change based on the epidemiological data, but in essence the criteria, the essence of the book has not changed?
Yeah, there was actually, we were forbidden
from changing.
But there were a couple, there's 8 criteria changes that were just mistakes that we had to fix. But we put out the DSM-IV, the message was you do not have to buy it if you don't, because your DSM-IV that you still have is still good. Yeah. But if you're interested in having more updated text, here's the DSM-IV-TR.
And then DSM-V?
So DSM-V was a similar kind of thing. They had to come up with a reason to do it. And there was a really big gap between DSM-IV and 5. So DSM-IV came out in 1994. I'll skip over the DSM-IV-TR because that was the same book. And DSM-V eventually came out in 2013. So it was quite a period of time. And during that time, people sort of fell in love with the advances in psychiatry. And one of the things about DSM that people find very frustrating is the superficial nature of the whole system. What do patients look like? How do they? And that only goes so far. And here we have, at the same time that they're thinking about DSM-V, this revolution in genetics and neuroscience, et cetera, et cetera. So they were convinced that information should be used to make a new kind of DSM. They were able to have biomarkers and get the biology as part of the system. That was their dream. That did not work out at all. This field is not, it's frustrating in every single level. Biomarkers is a good example. Why don't we have a biomarker at this point? And the reason is that in order to have a useful biomarker, you have to have a significant difference between if you have the condition, the odds of having a positive biomarker as compared to people who don't have the condition has to be big enough so the sensitivity and specificity that it's worth doing the biomarker. There's never been a biomarker in psychiatry that meets that requirement. So all of that biological material, which was important in aggregate, so that's the key thing. It's when you have your patient in your office where the biomarker isn't useful anymore. having biomarkers and discovering them for the disorder, that tells you something about the disorder itself, the pathophysiology, maybe for treatment. But when you actually have Mr. Jones in front of you in the office with depression and you want to have a biomarker for depression, it gives you zero information. So it's very, very, very disappointing. And genetics is the same way. There was a really huge interest in genetics in the late 90s and early 2000s. They thought, the Genomic Project come out, and they thought that the genetics was really going to open up the door to understanding what's going on. That also was very, very disappointing. So by the time they got a couple of years into the DSM-V, they realized that their dream of having a paradigm shift that would reflect all of this newfound knowledge was unrealistic.
So the data was not as great as it
Didn't
was supposed
exist.
to be, right?
I mean, it's really the brain. I mean, it's a much more complicated problem than people ever anticipated. That's really the problem.
No, there was also a discussion at the time about moving from the categorical sort of perspective to more of a dimensional perspective. So what happened there?
Well, the reason the DSM is categorical is that's the way doctors and people think. You either have a disorder or not. Plus, much of what you do in medicine is making decisions. Do I treat this person or not? Do I put them in the hospital or not? So having, from a diagnostic perspective, to have a categorical constructs that do have artificially sharp edges is actually very, very helpful. Dimensions, are mostly useful for severity issues, because dementia makes it clear that your severity of the conditions ought to continue. So the way DSM has approached that is they've added dimensions to the basic categorical approach. Now there's a proposal, there's a system that's come out recently called HiTOP. It stands for the Hierarchical Taxonomy of Psychopathology, which is a completely dimensional system. Now, a telling fact is the people putting that together are almost exclusively psychologists. Psychologists who do testing and all of that, dimensions are much more comfortable with dimensions, whereas psychiatrists who are rooted in medicine are much more comfortable and they find categories much more useful. So dimensions are part of what we have now in the DSM, but they threw out all the categories in HiTOP. It's just a bunch of dimensions. So it's sad because I think what's happened is when DSM-III came out, psychiatry and psychology sort of joined because psychologists use the DSMs as much as psychiatrists do because they found it very, very useful. If that HiTOP were to become a system, I think you'd have a split again where the psychiatrists would be using the DSM categorical system and the psychologists would start using this HiTOP type thing, and that would be sad to have that split again.
What about the NIMH research domain criteria?
Yeah, that's a different thing. So NIMH was the HiTOP was really addressing the poor way from their perspective DSM indicated dimensionality. The original work on the RDoC was they were very, very concerned with everybody knew at that point that the DSM system had a tremendous amount of limitations. The most important one is it's not closely connected to genetics or biology. It's too many genes for the same disorder and too many treatments that can work for the same disorder. It's not a tight match between the system itself and neurobiological elements. So there was a big concern that was going to hold up research. If you're using the DSM system to recruit patients for NIMH studies, and that's not the right system to use because it's too superficial, there was a lot of concern it was going to sabotage studies. So that's what got the NIMH to come up. So we got to come up with a completely new system. And their approach, unlike HiTOP, which uses the dimensions in HiTOP reflect comorbidity. So if two conditions are much more common together, they end up in the same subdimension. That really drives HiTOP. Where the RDoC system uses brain circuitry and domains of function that are associated with the brain circuitry as their main method, which is a completely different approach. And it makes sense. That seems like a much more promising approach if you really want to get into the neurobiology and genetics, because it's in the same realm. So I think RDoC has been very, very useful and helpful, and we have a lot of high hopes that studies using the RDoC paradigm will eventually produce information that could be useful in the DSM. Unfortunately, when RDoC first came out, Tom Insel started making these comments that I don't know NIMH is going to use DSM anymore, and that was unfortunate because he eventually walked that back.
Yeah,
he was very excited about his system, and I think he had, so they realized that you still need depends upon the study you're doing. There's studies where the DSM categories are appropriate, and there's studies where they're not. And the kinds of studies that the NIMH is putting money into, the DSM really isn't that helpful. So that's created that split.
So was there any consideration when the DSM-V was moving forward to actually include an RDoC-based approach?
Like with everything, RDoC has turned out, the same problem that plagues why the neurobiology and the system is separate is sort of the same problem. It's just not closely connected enough. There was originally talk of having, I don't know if it was a paper, there was going to be some kind of matchup or hope to have a matchup with what RDoC, I think somebody actually put together a table of what RDoC domains correspond to which DSM disorders or something like that. And I think that didn't go anywhere because the utility of that was found to be questioned. So that was the closest to actually join the two systems together. I think nowadays we see, we're sort of the DSM, we're waiting for RDoC to really uncover information which would be very helpful in improving the DSM categories. But the connection between the two wouldn't be that helpful.
Yeah. So DSM-3 to now, it's about 40 something years, almost like half century. Right. And I think it's fair to say that we made significant reliability gains. But how about validity?
Everybody asks that, and that's a problem. I mean, validity is first of all, what does it mean for something to be valid? I mean, what's happened is there's been a lot more thoughtfulness about what does it mean for something to be valid. And it turns out, this very interesting phenomenon is that, if let's say, for instance, you're using family genetics as your validator, could you expect disorders that are heritable to be much more likely in family members than in people who are other? Now, it turns out that other validators, like longitudinal course or biomarkers, don't necessarily end up the same direction. So you could have a biomarker or using family history as something that turns out would give you a different result had you use something like prognosis or longitudinal. So even there, it's hard to know what do you call something valid. So what the DSM has done, for DSM-V, they came up with some criteria for, like whenever a new disorder is added to the DSM, you have to work really hard to prove it to the committee. So they have a table of validators that you need to sort of look at the literature and fill out to really establish. So I think now the new, right now what DSM is not really in limbo. It's live because there's a steering committee that fields proposals from the field and from family members and patients. So that's an active committee that meets once a month. And so there's a mechanism for making changes to the DSM now on an ongoing basis. And part of that mechanism was to develop criteria for adding a new disorder or changing a criteria set. And one of the criteria for making a change is some evidence of validity. And that's where these validators come in. I think the rule is you have to show it's more valid on at least 3 important validators or something like that. So I think there's a really concrete attempt to make the DSM more valid that was never the case before.
Now, one of the things, talking about all these different editions, it seems like a constant through the iterations has been an increase in the number of psychiatric diagnoses from edition to edition to edition. It's not as high as people think. I actually was very curious about that. And it turns out the rule you use to count the number of disorders. And what happens if you want to make a claim like psychologists, there are 500 disorders in the DSM, and then the APA says, no, there's 180, something like that. They're both right. It depends upon how you did the counting. Like, is cocaine-induced psychosis a different disorder than amphetamine-induced psychosis? You could argue it got a different code. But you take all the substance-induced psychosis are kind of the same disorder. So that's how you can get into these games on how you do the counting. So if you want to make the point that there are too many disorders in the DSM, you could pick a counting method that goes in your direction. If you want to make the opposite point that the number of disorders are appropriate, you can have a different way of counting. So what about the conservative counting?
I think they're about
the same, or
well, it's gone up over time, and which is good. Part of what happens is we do discover, everything was at some point not otherwise specified. Like the most recent addition to the DSM was the addition of prolonged grief disorder. And the way those things happen is the phenomenon of individuals after the loss of a loved one, a year later, they're still wrapped up in it. That has been identified, but there's no they mistakenly said, oh, that's just an extended persistent depression. It's not. Those patients do not respond to antidepressants. So the treatment for prolonged grief disorder is a psychotherapeutic approach. So they sort of carved out of kind of this indistinct presentation of people who are experiencing grief, this subgroup of people which are particularly severe and for whom there is a treatment. So that was the impetus for trying to get that added to the DSM. And it took a few years to collect enough data for that to go in, but it recently, when the DSM-IV-TR came out, that was one of the new disorders in it.
With the functional impairment criteria, well, let me ask you that question first. So what's your take on the functional impairment requirement?
Well, one of the problems, conditions are on a continuum. This is like specific phobia is one of my favorites. Like being afraid of snakes in New York City, for example, that's probably not a disorder. If you live in Arizona in the desert, being afraid of snakes is a disorder. And the only difference is your environment creates more impairment than others. Your ability to avoid a snake in New York, it's very easy to avoid a snake. Just don't go to the zoo and look at the snake pit. Whereas in Arizona, if there's a possibility of a snake anywhere, you may end up being housebound during the time of year where the snakes are active. So that's why impairment really helps define. You need something to define the boundary between disorder and non-disorder. And there are two elements. It's either the impairment, functional impairment, or distress. Some people may not be impaired particularly, but they're miserable. The symptoms are so severe and so distressing. Those people could also qualify as having a disorder. But you need to have some way to distinguish normality from the disorder. And there aren't any biological markers for that. It really comes down to functional impairment.
Yeah. No, what's interesting about that is that the intent there is that, is sort of to narrow and consolidate the diagnosis, right? To kind of get rid of the potential false positives. But at the same time, you could imagine how the same neurocircuitry that's going to manifest in a dysfunctional way and result in a given phenomenology if the individual reactions to whatever that phenomenology is going to be distressed. With the same neurocircuitry dysfunction, you could get or not get.
No, exactly.
The diagnosis.
I mean, what it's saying is, it's the reality that the diagnosis depends upon the environment and your own internal disposition to develop distress. So it's very, very complicated. So I agree. The snake example really talks about the environment. There's also different people would respond to trauma very differently. It's well known that the same exact trauma will have a third of the people will develop PTSD, but 2/3 will not. What is it about what's causing that? And certain people are more susceptible when they get exposed to trauma to the neurobiological reaction. So there's individual elements plus the environment, and the way you can piece that apart is you look at something like functional impairment as a marker for what we're going to consider. It's very practical, actually. It's sort of like we are trying to help patients and treat them, and we want to treat people who are functionally impaired and distressed. So that marker, and that's why we use the phrase clinical significance. That's the clinical significance criteria. Say this is the kind of person who would benefit or deserves treatment because they're suffering enough and they have enough functional impairment. So again, it's not scientific. It's a clinical type marker for what you would consider a disorder.
Comorbidity. Is it real or is it an artifact of our...
It is definitely an artifact. It's real and an artifact. I mean, comorbidity simply means a basic level, meeting the criteria for more than one disorder. Yeah. And when you have 150 disorders, the odds of meeting criteria for more than one disorder just goes up. If there are only 5 disorders in the DSM, then there'd be very little comorbidity. But when you have 150, it's much more likely to do that. And so what does that mean exactly? Is that true comorbidity? When the term comorbidity was originally coined back in the 1970s, the classic comorbidity was something like heart disease and arthritis. They're 2 separate illnesses with separate courses. In psychiatry, since we don't know that much about the pathophysiology, we can't really use that criterion. But there is this concept that the comorbidity makes sense when there are 2 entities there that have at least some degree of independence to call it comorbidity. But when you have the kind of comorbidity we see in psychiatric disorders, where people have 5 disorders, very often internalized. So you'll have depression, you'll have anxiety, somatization. Those go together because probably there's an underlying common cause to all those conditions. So I think what I always say about comorbidity, yes, there's a lot of it. If you understand what it is and what it reflects, it basically tells you it's a complicated case. This person has a lot going on, but they're really not separate conditions.
Yeah, and I think there is something to be said about primary versus secondary. I don't think that at times this consideration of what's driving the rest of the clinical picture is taken really seriously taken into consideration, which could then result in a false increase in comorbidity.
Exactly, absolutely.
Yeah. Underdiagnosis or overdiagnosis with our current edition? What do you think it's?
Well, if I were Alan Francis, I would claim there's overdiagnosis all over the place, and I've gotten into some serious arguments with him because I worked with him very closely on DSM-IV, and then when I ended up working on the DSM-V and he was not working, he sort of saw me at some point as the enemy, we're still very, very close, but we have very different perspective about overdiagnosis and underdiagnosis. And part of it what happened with him is he's very concerned about the stigma of having a label. And he's willing to not treat people just to avoid the stigma. Where I am much more concerned about treating people and reducing their suffering. So, something as simple as like prolonged grief disorder is a good example where people were worried about. That's a tough one, but grief is normal. So whenever you have a condition where the main symptoms occur in normality, you have to figure out how do you define that grief in such a way that you're really capturing disorder. One of the ways is prolonged grief. The essence of it is prolonged, means that it's more prolonged as you would expect in a normal person. The amount of time that you have to have it to consider it the disorder will affect the prevalence and could cause overdiagnosis. So the DSM came down eventually on a year of symptoms. Now that's recognized. For some people, a year is probably too short. Some people would probably benefit from prolonged grief treatment if it's only 6 months. And then some people like Alan Francis say, a year, you have that, the anniversary of the death or whatever. So they feel like you should wait a year and a half or 2 years. The longer you have to wait, the less false positives there will be. But look at all the false negatives. It's the problem in anything. So you pick whatever threshold and you're worried about being over it or not, then you're going to lose patients on both ends. And I think that, I'm being a clinician, I'm more eager to treat patients than I'm less concerned about them. Maybe that's my perspective working in diagnosis for 30 years, that having a diagnosis, a false positive seems to me to be less of a harm than missing out on really helpful treatment. But that's, again, it's a perspective. Alan has a very different perspective.
Where do we go from here?
Well, the DSM, we'll see what happens with, hopefully when they start work on the next DSM, there will not be searching for another paradigm shift when there isn't one to be had. I think the system will continue to evolve, and hopefully the science something will happen to really change things. But if I said that, I can't tell you how many times I've had that thought and have been disappointed. So I've toned down my optimism and expectation. And I see DSM with all of its flaws continue to be very, very useful in identifying and communicate with people. And one of the biggest things is even though the connection between diagnosis and treatment is a little loose, having a diagnosis, what that tells you is where to go look in the literature to find things about the treatment. It's a very good organizing principle to try to connect diagnosis and treatment. So I think that value alone makes me feel like I think the DSM is worth keeping without fiddling with it too much.
Yeah. So we don't know when the next edition will come out.
No.
It's too early. But if anyone can make a prediction about what that's going to be like, you are probably one of the best people who could predict anything about the next edition, whenever that's going to come. What do you imagine it's going to look like?
I can't even, I think it's the paradigm. I think I imagine it's going to look a lot like this. I think the same, overly optimistic belief of having a paradigm shift, I think people learned a lesson with the DSM-V. So I think it's going to be a much more, making changes around the edges. One idea, I think, including more social determinants of health. There's lots of sort of things that could make the DSM better. So I think what will happen is the DSM will continue to improve and continue to be more useful. But I think the problems of being too superficial and comorbidity, they're just going to be there. And I think you just have to live with it and wait around for the moment in time where those problems are solved.
Michael, any concluding thoughts?
Well, I've been, working on the DSM for a long time. It's been very interesting seeing how it's evolved. And I continue, it gets a lot of pot shots. needless to say. So I still feel really good about being involved with it because I still consider it to be very, very useful. So I've been very thrilled to be a part of this journey of the DSM.
And I want to thank you for everything you've done for our psychiatric diagnosis and classification. I think it's been a tremendous effort, and your efforts have been crucial in getting us from where we were 50 years ago to where we are now. So I'm very grateful to you. I mentioned, when I was talking to you before this interview, I somehow found the DSM tapes when I was an intern. That was 1996, and I was going through the tapes and to the video training for SCID.
Yeah, right.
And to me, back then, it felt like the world of diagnosis was not very well structured, and that put things for me in order. So I'm very grateful to you, and thank you so much for making the time to talk to me today. I appreciate it.
My pleasure.
Yeah. Take care.